And perfect. So thank you, everybody. And this morning, I'll welcome again Dr. Saurabh Gupta, who's one of our new recruit for us for cardiac surgery here, but in more than a year from now. So, but he's in Edmonton currently, and he was presenting some of the stuff yesterday at his journal club, and we thought we'd take advantage since it's obviously one of those things that we debate sometimes in terms of the indications, the usefulness in ECMO, and there's very little randomized data, as you might imagine. So it's worth at least having this discussion. And we've got Chris on the line, so we've got some experts, and we've got lots of our clinical cardiologists across the province here and from here that are on the line also. So ECMO in cardiogenic shock, a randomized clinical trial that has recently been published that is worth certainly reviewing in terms of what did we learn from this, what did we not learn, pros and cons and all of those things. So with that, Saurabh, all yours.
Thank you, Dr. Legary. Yeah, like Dr. Legary said, my name is Saurabh Gupta. I'm a cardiac surgery fellow currently in Edmonton at the Mazankowski, and I'll be joining Ottawa for a year as a fellow in structural heart doing TAVIs and mitral clip before coming to St. John, New Brunswick, and starting my career there. So very excited for that. And like Dr. Legary said, today we'll be discussing ECMO-CS, the randomized control trial that was just published in Circulation. I was trying to step away from a journal club style presentation for these rounds and kind of present more from a discussion perspective and have a idea of sort of what this what the realm of this topic has in terms of data that's randomized and that's robust, and there's really not much. So this is kind of the overview of what we'll be doing. In terms of background, the things to remember is that the definitions of hemodynamic cardiogenic shock, when you look at observational studies or randomized trials, when it comes to ECMO data, is sort of all over the place. And what I mean by that is, while some data will look at it from a clinical perspective, others will look at it purely from a hemodynamics perspective. And for the trial that's in question today, and in general for our conversations, I think the SCAI classifications for shock have kind of become the go-to in how we look at it. What I'd like to point out here is that Class C is usually thought of as the point at which we should start having that discussion with the shock team about MCS, including ECLS and not just balloon pump. And really Class D and E are when patients are either deteriorating to the point where you are doing emergent ECMO or emergent ECLS. And of course, extremis could be anything from ECPR to really just sort of salvage things. The background in terms of the guidelines is that there really is no guideline specifically when it comes to ECMO or ECLS in patients with cardiogenic shock. The European Society of Cardiology really is the only one that has even a class of recommendation, which is a 2A, which is quite a strong class of recommendation given the level of evidence that you may strongly consider MCS for hemodynamic stabilization in patients with cardiogenic shock. And what's interesting is they go on to also say that, you know, it's not just for patients with MIs, it's not just for patients with post-MI complications, it's even for patients with pulmonary myocarditis and other conditions causing severe cardiogenic shock. And there's a whole list of these, and we can talk about that and see what the thought is in New Brunswick about using ECMO for those patients. And of course, you have the Acute Cardiovascular Care Association of ESC, as well as the American Heart Association, which more so have given statements that you can consider MCS escalation really for select patients with cardiogenic shock, but really no guidelines per se. Before the most recent trial, there was only one other trial published and in this topic, and it was a monocentric open label randomized controlled trial that was published in 2019 in JACC. Interestingly enough, if you look at the publication, it reads more like a letter. It's about a page and a half. It's a very quick publication. It evaluated ECLS versus conventional therapy in a total of 42 patients, 21 in each arm. The primary outcome here that they looked at was LVEF at 30 days, which was their surrogate marker for myocardial recovery. And there was really no difference between the ECLS and the conventional group. And the secondary outcome, which again, they were not powered for, which looked at mortality, was significantly lower in the ECLS group. However, again, they're not powered for it. It's a secondary outcome. You can't really make any far-reaching conclusions based on that. In fact, even for their primary outcome, looking at LVEF at 30 days, I'm not really sure you can make much conclusions on a trial of 42 patients. And there was no difference in rates of stroke, peripheral ischemic complication, bleeding, reinfections, etc., which tells you really that this trial, ECLS, was safe in terms of adverse events, because obviously with ECMO, is not without its own complications. We always worry about those. Interestingly enough, the trial that we're looking at today, we'll discuss the adverse events there as well. This is a summary. It's a busy slide, but I'll try to just give you the gist of it. And what you're really getting at here is that the authors concluded that the trial shows that VA ECMO early among patients with deteriorating or severe cardiogenic shock, so that's SCI D or E, not C, did not result in superior outcomes compared with initial conservative care. And I would say that's the author's conclusion, and that's what was published, but I don't necessarily agree with how final that conclusion is, and we'll talk about why I say that. The endpoint here, their primary outcome, was a composite of all-cause mortality, implementation of another MCS and resuscitated cardiac arrest, and that showed absolutely no difference between the two. And the individual components of those composite outcomes were no different either. What's interesting is that, well, actually, I should skip ahead, but we'll talk about that. So study design. So this is the first large RCT looking at this topic. It is multi-centric, mono-country. So this was done in the Czech Republic at 4 centers. It randomized 58 patients to VA ECMO and 59 patients to conservative therapy. The primary outcome I've already talked about was a composite of all-cause mortality, implementation of another MCS, and resuscitated cardiac arrest. Enrollment was immediately on diagnosis, and if a patient was too sick to give consent and a family member was not available, it was implied consent, as happens a lot of times with these kinds of situations where you can show equipoise to your REB, and then consent was given retroactively, and actually 5 patients withdrew consent for their data to be shared, and that's why the number came down to 58 and 59. They didn't, in fact, enroll 5 more patients. Inclusion criteria, again, a busy slide, but the thing to take away here is that it was rapidly deteriorating cardiogenic shock corresponding to SCI D or E, and the severe cardiogenic shock data was based on hemodynamics or metabolic, and you had to have excluded hypovolemia. So your CVP could not have been less than 7, your pulmonary capillary wedge pressure could not have been more than 12, just to give that idea of, you know, this is not hypovolemic shock, there's not bleeding happening from somewhere, etc. The exclusion criteria I thought was quite interesting. The age, of course, makes sense. You know, you're looking at adults only, you don't want to include children. However, whereas most centers would have an age restriction to who they initiate ECMO on, I know here in Edmonton, 70 is a pretty hard cutoff. The trial did not have an age cutoff. The trial had a life expectancy cutoff, and the life expectancy was less than 1 year, which again, I think is a little liberal. You know, if someone had a life expectancy of just 2 years, I don't know how everyone feels about initiating ECLS on a patient like that coming in severe cardiogenic shock. Interestingly enough, if you had a suspicion for PE or tamponade, ECLS was not considered. I think tamponade makes sense. It's something that can be intervened upon either by our cardiology colleagues or by ourselves, depending on the effusion. But to not include PE, I thought was interesting because that is a condition in which I've seen ECLS be used, especially in young populations, and have good outcomes. Bradycardia, tachycardia, not treated, of course. Comatose cardiac arrest, of course. interesting, HOCM patients were not included, and I think that's because, and again, I'll throw this to my cardiology colleagues, perhaps they would agree or can shed more light on it, but I think classically, the conventional therapy for HOCM patients in cardiogenic shock is very different, or can be very different, than the conventional therapy in most other patients coming in with cardiogenic shock. You know, you're not putting these patients on necessarily on inotropes, and that can kind of muddy the waters, and I think that was fair. This was a cardiology-driven trial, and what I mean by that is that all the ECMO cannulations were done percutaneously, peripherally, and so peripheral arterial disease was an exclusion criteria. There was no cut downs done, there was no central ECMO done, and we'll talk about how that sort of lack of collaboration can cause some issues and critiques of the paper. Moderate to severe AI not included, aortic dissection not included, major bleeding not included, encephalopathy not included. This other salient features and characteristics I thought was very interesting as well. You know, of course, the chronic heart failure piece makes sense, that 1 in 4 patients who had a history of chronic heart failure. The lactate, sure, makes sense. Mechanical ventilation at randomization, 3 on 4, makes sense. Balloon pump at randomization in about 15% of patients, I think makes sense, depending on what they're coming in with and what their initial pathology was. What I found interesting at a personal level, and again, I'd love to hear the thoughts of colleagues in New Brunswick, and what's done is, you know, of course, it makes sense for levo to be, or norepinephrine to be, the most used vasopressor. But what I found interesting was that in terms of inotropes in a patient with SCI, D, or E cardiogenic shock, epinephrine was only used in about 3.4% of the population, whereas, you know, 55% were on dobutamine. Nothing against dobutamine, I just have always, in my experience, seen norepi and epi be kind of the go-to in someone who's coming in with extremis or sort of, you know, escalating cardiogenic shock, and less dobutamine. And milrinone was used in about 1 in 3 of population, which again, quite surprises me. Vasopressin 35%. Half of the patients were STEMI patients. 12% non-STEMI. Mechanical complications accounted for about 2.5%, and then the rest. The bottom part there is very important. The crossover to VA ECMO in the early conservative arm was about 40%. And I think that's where we have to take the conclusions of the paper a little bit with a grain of salt. And again, we can talk about that a little bit more. Primary outcome, again, 64% versus 71.2% in the VA ECMO versus early conservative arm, showing no difference with the hazard ratio of 0.72. Numerically favors VA ECMO, and I'll qualify as to why I said numerically, even though the trial technically is powered for this outcome. Secondary outcomes, this is a very busy slide again, but what I think the takeaway here, oh, sorry about that. The takeaway here that I'm trying to say is that, you know, the secondary outcomes, each of them no different, but again, they're basically hypothesis generating. They looked at adverse events, everything from bleeding, ischemia, stroke, pneumonia, sepsis, technical complications, and then looked at number of adverse events per patient, you know, 0, 1, 2, 3, more than 4, no difference across the board. And it doesn't surprise me given the crossover rates, right? So let's say you are saying ECMO is associated with higher complications, and potentially might be, but if you have 40% crossover to ECMO, you know, that's a large population in the conservative arm that may still be prone to those complications. And of course, cardiogenic shock patients themselves are going to have a higher risk for a lot of these adverse events to begin with. Interpretation. So like I said, this was the interpretation of the authors of their own trial. Early VA ECMO and cardiogenic shock patients did not result in superior outcomes compared with the initial conservative care. Does provide important data. I agree with that for the field and patient population in whom VA ECMO has increased dramatically in the last few years. And there's no randomized data that shows clear benefit. I would agree with that as well. However, I think the caveat here needs to be the critique of the paper and the critique perhaps of how we approach this patient population. You know, generalized critique of most trials like this is, of course, that it's open label. You know, it cannot be generalized to any other ethnicity or race. It's a small sample size with no subgroup analyses really possible, a very high crossover rate, which was part of the secondary endpoint definition. So when you look at initiation of another MCS in the conservative care, that included VA ECMO. Now, this is where I'd like to expand a little bit more and talk about the fact that, the trial outcome really is not looking at ECMO versus conservative therapy. It is looking at early ECMO versus early conservative therapy. And I think that's where we have to be careful that, yes, there's crossover, but they didn't talk about eventually being able to get on ECMO. They're just talking about what happens when the patient initially comes in. The caveat is that the authors don't really ever define what that time period is. What does it mean to be early conservative therapy? Is it the first 30 minutes? Is it the first hour? Is it the first 5 minutes? Or is it the first 24 hours? There's really no sense of that in the paper. And as I'm sure our colleagues have been there, sometimes in this patient population, it can be a matter of minutes to barely hours before you have to escalate to other means. And so that's a little bit interesting. The other thing is a colleague of mine, one of the intensivists here who I was discussing the paper with yesterday, last night when I came into the hospital, was there's that idea that, well, 40% crossover means that early conservative population, 60% were able to, quote unquote, avoid ECMO. The problem with that thought process is the paper presents as a randomized analysis, not an intention to, it provides an intention to treat analysis, not an as treated analysis. And so we don't actually know if those 60% in the conservative care group had just the same outcomes or better outcomes than the ones who did cross over to ECMO. And without knowing that, we can't really say that, well, 60% of patients avoided ECMO. Sure, they avoided ECMO, but did that mean that they had just as good outcomes, or did they have worse outcomes? And that's why they were not ECMO candidates by the time these things happen. So I think that's one. Low use of LV venting. And this I found extremely concerning, because I think in general, LV venting is something that is extremely important for a sick, stiff heart. And there was extremely low use of LV venting, if any, in this population. And I think that's another thing as a shock team we have to be aware of, that these are sick hearts, and if someone's coming with a STEMI or an NSTEMI and is requiring ECMO, you may put them on ECMO just to stabilize them in that moment, but really there should be a plan for how are we going to vent this patient? What are the hemodynamics going to look like moving forward? I think that LV vent piece is extremely important. It was powered for the composite outcome. However, the power calculation assumed a 50% reduction in the primary endpoint with the VA ECMO, which I think is quite aggressive to expect a 50% reduction with ECMO versus early conservative care when you're allowed a crossover. I looked through some of the observational study data out there, and even looked through sort of, anecdotally, what are the outcomes here in Edmonton. I think at best, if you're looking at a composite outcome like this, where you're allowing crossover, you can maybe expect a 25% reduction, but I think a 50% reduction is far overreaching what we're treating here. This is a very sick population that you're really doing salvage procedures and salvage management on, especially in SCI D or E. And to expect, I think, a reduction by half in what we're looking for, I think is a little bit overreaching. Larger trials are ongoing, quite a few of them. And that's about it. We can go on to questions, but I just want to say, I think for me, I think if you look at all these papers that are out there on ECMO, whether it be in the ARDS population with VV ECMO, whether it be everything that we've learned from COVID ECMO, and I'm sure Dr. White can speak to it a lot more than I could ever, given his training and background. I think the conclusion always comes out to ECMO for some and not for others. But I think what's very important is to have the shock team which should include, our cardiology colleagues, our cardiac surgery colleagues, our intensivist colleagues at the minimum, be involved earlier rather than later. I know that's not always possible. Sometimes patients just come in extremis, and that's understandable. But I think when we have someone in cardiogenic shock or headed towards Sky D, who's still in that Sky C, that phone call to the team should happen. And what that can allow us to do is we can ask for, let's get better hemodynamic numbers. Let's put a PA catheter in and really look at how this patient is looking. There seems to be this fear of intubating patients, even in this trial, which is quite aggressive. You have Sky D or E, cardiogenic shock, and only 70% of patients were actually on mechanical ventilation. Perhaps we should mechanically ventilate this patient, take over the ventilatory effort, and start to adjust some of that metabolic abnormalities ourselves through ventilation, which is possible. Maybe we need to get a TEE and really look at what the heart is doing and what the valves are doing and how bad is the LV looking, and get some idea of what the cardiac output truly is. And I think the sooner the shock team gets involved, the sooner these hemodynamic criteria, these hemodynamic numbers are sort of elucidated, I think the better the outcomes can be, either through conservative management or through earlier initiation of ECMO, if you would. And I'll just leave it at that. Questions, discussion points?
Yeah, thank you, Saurabh. This is I think that the commendable part of all this in my mind is that they achieved the trial, which is unbelievable. I'm sure difficult. And as you pointed out, I wonder if you can sort of illustrate a little bit based on the methodology, how they approached the patients from the outset, constructed their, algorithm in terms of selecting the patients, PA catheter measurements, and all those kinds of things before entry in the trial. Was there a little bit of a description of that?
There was some.
Because I think you highlight the biggest issue is, out of the 60 or so that were randomized to conservative group, 25 of them or 24 went to it was, I'm sure, an intention to treat analysis. So based on that, you already, no kidding, the complication would be similar between the groups.
Yeah. So, their idea was that both hemodynamic and metabolic criteria had to be met, and that included a cardiac index of less than 2.2, that included a systolic blood pressure less than 100, specific doses of norepi, specific doses of dobutamine, specific echo criteria with LVEF and severe MR. That was just the hemodynamic criteria. And then, of course, the metabolic criteria, which they looked at either lactate or they looked at SpO2. So I think, patients had PA catheters in for them to be able to judge a lot of those things. And B, patients had very aggressive sort of repeat echoes and echo numbers and echo criterias and things like that before they considered enrollment into this trial as Sky D or Sky E. And I think that's perhaps what you're getting at. A lot of times those numbers are just not available to us when patients are called.
Yeah, and I wonder if Chris would comment also, and I think in my mind it highlights again the high selectivity and make sure that we make the right choice in these patients.
Yeah, I think you did a really good job of highlighting the pros and cons of this trial. I mean, this data is better than no data, but it's a messy trial to try and unpack. Patient selection is the biggest part of success in mechanical support, and that it's a hard thing to, yes, there are numbers and criteria we use, but there's a lot of decision making that goes on that is hard to quantify in inclusion criteria in a trial. I think this trial is really about early ECMO versus ECMO as an option, as you pointed out. And the stage D, these criteria, we certainly would not put someone on ECMO that has a cardiac index of 2.1 on 0.15 of norepi and a lactate of 3. I would argue that is aggressive therapy for that kind of a patient. A stage E patient is easy. A stage D patient, with a mixed venous SAT in the high 40s that's making some urine, lactates 3, 4, that's a patient we would probably follow closely and try to optimize medically. So for sure, ECMO is not the treatment for every patient that comes in shock, and I think this trial demonstrates that. But a lot of these battles are won and lost in the ICU management. And, you know, for example, 14% of people had ischemic legs, and in my mind, that number should be near zero. You know, and ischemic limbs are often fatal complications. And in my mind, it's a bit of a marker of how these people are managed. You know, that really shouldn't happen. Every one of these patients should have a distal perfusion catheter and distal limb monitoring. So I think this is a trial saying that, you know, early ECMO is not necessarily beneficial, though despite that, you know, I agree with your discussion around the primary endpoint and how they base their power calculation. A 50% reduction is a pretty impressive goal to shoot for, since you're allowing crossover. And, you know, I mean, if you get a sense that with a bigger trial, bigger numbers, that endpoint would have been significant. And hopefully these upcoming trials will shed more light on this, and hopefully help us, you know, refine our selection criteria. At the end of the day, mechanical support is a tool in our toolkit, but it should not be a blind blanket application to every person that comes in shock. And that's why I think shock teams and multidisciplinary discussions around a patient with data at hand is the way these decisions should be made. So I agree with JF. I think they should be commended on actually conducting this trial. I can't imagine the effort it took to do this, but there's it's a bit of a difficult trial to really make big, hard decisions about our own conduct of managing these people.
Perfect. With that, yeah, go ahead. Who's got a question?
Quick question. Yes, it's Yemi.
Yes. Hi, Yemi.
Thanks, Saurabh, for that excellent presentation. Just a question about the statistical analysis. You know, I think you mentioned the intention to treat was the way the results were presented, which is standard for clinical trials. Did they present as a secondary endpoint the as treated or per protocol analysis? Because that would be surprising if it's not presented.
So the reason it's not presented is because we have to look at, so the idea, as Dr. White again highlighted, is that they did not compare ECMO to conservative management. If they had done that, then they would have to present the as treated analysis, because then you're looking at the crossover as a problem. And that was done in some of the ARDS trials for VV ECMO, which was just looking at ECMO versus conservative management. This really looks at timing, early ECMO versus early conservative management. And then once that early time period is done, you can do whatever you'd like. Either you can change over to ECMO or some other MCS, Impella, whatever. And so they're not really beholden to an as treated analysis, because what they're showing is timing rather than ECMO versus conservative management. The problem with that, however, is that they don't really elucidate what that timing is. What is the definition of early? What is not? So
I agree, but I can sort of see what Yemi's point is
of course, yes.
Like, why not show me those 80 or so that had ECMO against those 40s that did not? Like, how does it look? Like, I'm curious. I want to know.
Absolutely. As do I. But it is not presented, and it was not asked for. And that was the discussion that we were having yesterday as well, as to, you know,
it's coming next year.
And that's right. Yeah. And usually, like Dr. Legary said, it's actually, it's very true. Sometimes these things do get presented as a second publication, you know, as a follow-up. And we've seen that happen in one of the larger cardiac surgery trials, the ART trial, that looked at arterial grafting. They looked at BEMA versus SEMA, but there was a huge crossover with radial arteries. So, you know, they presented the data initially as intention to treat, and then down the road as an as treated. And I think hopefully the authors are working on an as treated, just looking at all the ECMO patients versus just the conservative management patients. But I agree with you, that would be a very interesting analysis to look at.
All right, guys. So with that, I think we'll close this morning. We're past our time. So again, thank you, everybody. Thank you, Saurabh, for getting up really early and taking care of that for us. Have a good day, everybody. Bye-bye.
Thank you. Thanks for having me.